afternoon to all of you. After the excellent presentations of this morning, we will continue sharing the international experiences on risk events for health. And this time we have three excellent um, speakers from the CDC. And for that, and for the moderation of this space, I would like to invite Dr. Eduardo Gotuso. Dr. Gotuso is a surgeon, master's, PhD in medicine by the Cayetano Heredia University. He's a specialist in infectology and internal medicine. He directs several projects with international support that allow them to make a research on young students. He was the first Peruvian and being president of the International Society of Infectious Diseases. He is a joint professor of the training program for Latin America, J. Harrington, in the University of Miami and the John Hopkins and the Department of Medicine in Alabama. He is an honorary member and advisor to several academic international organizations, and he has 502 papers that have been published in Peruvian and international magazines, and he participated in 47 chapters of different books in Peru, Latin America, United States, the UK, and he has published 2 books and 6 manuals are highly important for public health. Today, he is a professor of the Cayetano Heredia University and main professor of the School of Medicine of the same university, chief of the Department of Infectious Diseases and Tropical Diseases of the UPCH, and a director of the Alexander von Humboldt Institute. So, Dr. Gotuso. Thank you very much, Dr. Bengolea. The last 2 positions that you mentioned, well, I already fulfilled that. I'm a former chief. So thank you for that invitation and for allowing me to moderate this important session. And I thank the organizers to allow me this honor. Today we have 3 presentations. Andrea McCollum from the CDC. She is a sub-director in Varela and at the CDC, and she will do a presentation. And then we'll have questions. So we will cover that subject. Well, without further ado, I would like to introduce Professor Andrea McCollum. And welcome. You are the next speaker.
Thank you very much, and thank you for having me. I unfortunately do not speak Spanish, so I will try to speak slow for the translator and ask that they let me know if I am moving too fast. Can you see my slides? Can someone please confirm? Yes?
Yes, we can.
Thank you very much. So again, I'm happy to be here as part of the CDC response team, and also in my day job prior to this response, I specialize in pox viruses and monkeypox. So just a quick update of where we are now, July 11th. As of July 11th, we're at 866 cases in the United States and Puerto Rico. And then worldwide, we're quickly approaching 10,000 cases across 63 countries. This is just a simple epidemiologic curve of case confirmation, number of case confirmation by week. And this last week right here is the current week we're in. So this bar certainly will grow taller. This is the age distribution of many of our cases with age data that's available, and you can see most of the cases are less than 40 years old. What's not presented here also is the overwhelming majority of our cases, over 90%, report male sex at birth. So I do frame a lot of what we're learning about the current outbreak in context of our historical understanding of clinical presentation of monkeypox. And I think this is quite important because there are some key differences that I think are really important to point out to clinicians as they're beginning to think through and see patients, and in hopes that they actually also correctly diagnose or think about monkeypox on the differential and request testing. So historically, monkeypox is the disease where there is a febrile prodrome that may consist of fatigue, headache, respiratory symptoms, lymphadenopathy, and a high fever that's present a few days before the rash begins. The rash is very characteristic with some of the characteristics listed here, and I'll show you some photographs in a minute. It's often present on the palms and the soles, palms of the hands, soles of the feet. And often is seen as a single stage of development on a given side of the body. So that means all vesicles on the arms, all pustules on the face, all crusts on the feet. An illness may last for as long as 4 weeks or more. So here's some photographs of these characteristic lesions, and these were all taken prior to this global outbreak. And what you see kind of on the left are lesions from a US outbreak in 2003, and sort of on the right are photographs taken more recently in Central Africa. And these really emphasize the characteristic lesions. You can see that they're very, what we in English, we call them very well circumscribed. So they look like defined circles in terms of the borders. Often later in the stages of development, you see the central umbilication, which is demonstrated on the hand on the right. You can see the lesions on the palms. These lesions are what we call deep-seated. They are sit through several layers of the epidermis. Patients often describe them as very painful. And certainly early in the course of illness, which you see on the far left over here, top left, it can be a little bit difficult to sort of see this defined characteristic lesion. Co-infections with other infectious agents do occur, and they may cause additional difficulties with clinical recognition and diagnosis. Of note, varicella zoster virus co-infections have been noted to occur in areas of Africa, and co-infections with other common sexually transmitted infections, including herpes, gonorrhea, and chlamydia, may occur and are being seen in some of the reports from both the United States and in Europe. So we think it's very important for clinicians to do a full skin exam of a patient, as well as an exam of the oral cavity to see if any lesions are present and what these lesions look like. In the instance of co-infections, you may see different characteristics depending on the lesion. So again, some of the key differences that we're seeing in the patients as of July 10th, about 65% of our patients report prodromal symptoms, whereas our historic understanding of monkeypox, close to 100% would report prodromal symptoms. Many of the patients currently are reporting rash beginning on the genitals or perianal area. And historically, most patients normally presented within the rash would begin on the face or in the oral cavity in the mouth. Lesions also currently are not always widely disseminated across multiple sites of the body, meaning most sites of the body. Instead, sometimes patients are presenting with lesions only on 2 or 3 sites of the body. For example, genitalia, arm, face. And then some of the symptoms that we're hearing about a lot is that patients may be initially reporting with symptoms of anorectal pain, very severe pain that's associated with an eventual, usually a diagnosis of proctitis. And often patients don't even realize that they have lesions until the clinician does a full evaluation, including the skin exam and also an exam of the rectal anal area. So these are some pictures from more recent patients. I think these are some of the better pictures out there from the UK Health Security Agency. And you can see here, some of these lesions are very characteristic for orthopox. You can see that central point of umbilication. They're often very well circumscribed. But very early on in the course of illness, which I think is really demonstrated in that photograph at the top, in the middle, and top left. Sometimes it's not immediately evident that this may be a pox virus. And so it's important for clinicians to see these photographs as well as others that may be available online and utilize them in their own practice as they're thinking through differential infections. The laboratory diagnostics for orthopox viruses, and I want to take a step back. Monkeypox is an orthopox virus. It is one species of virus. Another orthopox virus is variola virus, which causes smallpox. So they're very closely related. Right now in the United States, and I think many of the laboratories around the world, they're using PCR for both orthopox specific and monkeypox specific PCR assays for diagnosis. And that's achieved on lesion specimens. So specimens of the rash itself are usually the best specimens for diagnosis. The rash, all the lesions, they're basically viral factories and they have a ton of virus in there. So in the United States, we've been using the laboratory response network labs. These laboratories are at many of our state health departments and some of the major cities. For example, New York City has a laboratory response network lab. As of last week, commercial laboratory testing has begun at one of our larger commercial laboratories in the United States that accepts specimens from many clinics. And more commercial laboratories are going to begin accepting specimens for monkeypox testing in the coming weeks. The orthopox-specific PCR test, particularly currently now and in the context of this global epidemiology and the patients that we're seeing in the United States, is sufficient and actionable for clinical treatment and public health measures under a presumed diagnosis of monkeypox. Labs are then able to send additional specimens to CDC for monkeypox-specific characterization. Transmission of this virus is here on the slide. This is a zoonotic virus. It originates in animals and is transmitted to humans. And then so you see subsequent human-to-human transmission, which is what we're really seeing now in terms of the global epidemiology in the US and in other countries. There are several routes of transmission. This includes respiratory droplets or secretions, contact with the lesions themselves. The lesions are infectious at all stages until the crusts separate and a fresh layer of skin is formed. Urine and feces have been noted to contain live virus in animal models. These viruses are very hardy and may persist on surfaces. The good news is that several straightforward disinfectants, such as the use of ammonia or bleach or other compounds, easily kill it, and they're very susceptible to ultraviolet light, like sunlight. As well as transplacental transmission can occur to a fetus. So thinking through some of the epidemiology we're seeing in the United States, it is very consistent with the epidemiology that we're hearing a lot out of Europe and even some other areas of the world, where it seems as though that close sustained contact, often through sexual behavior, is likely to be the route by which people are infected. And given the high proportion of men, that's why you're seeing here a discussion amongst 57 men. Of these men, we also most of the patients are reporting sexual contact with other men. And if asked about their number of male partners in the 3 weeks prior to illness onset, the overwhelming majority of them have more than one partner and even more than 3 partners. If asked about how they're meeting sexual partners, Given the number of partners, these are the variety of ways that they are reporting. Again, very consistent with what we're hearing out of other countries. So using an online app, going to clubs, bathhouses, sex parties, or other social events where this may occur. So prevention for monkeypox is really based on tried and true public health prevention steps, including, quick clinical recognition and testing, patient isolation, and risk mitigation of spread to others, infection prevention and control in healthcare facilities and at the residence, identification of exposures and contact tracing, as well as a variety of engagement that we're actively involved with at CDC, including with clinicians, with public health partners, and with specific communities that may be at higher risk of infection and dealing with this right now. Particularly, we have a lot of engagement with the gay, bisexual, and MSM community now. As well as previous smallpox vaccination does provide protection. Smallpox, as I mentioned, is caused by an orthopox virus. Vaccination with one orthopox virus provides cross protection against a variety of other viruses. So in terms of the two vaccines that we have in the United States that are stockpiled and are put to use right now, the first is Jynneos. This is also the one you're hearing about a lot from Europe. This is a vaccine that does not replicate efficiently in human cells. And it is being offered to people for protection against monkeypox. The second is ACAM 2000. This is very similar to some of the vaccines used during smallpox eradication, where you have an inoculation on the skin, often on the arm, that then stimulates an immune response to provide protection. We are, in the US, we have begun to explore vaccination strategies in the last couple of weeks. So when we first started, we focused on a post-exposure prophylaxis targeted for intermediate and high-risk contacts. As the epi data came in and this developed, and hearing from other partner countries such as Canada and the UK, we quickly realized that a lot of these individuals who were reporting particularly sexual contact were reporting a large number of contacts, and a high proportion of those contacts were anonymous. So it was virtually impossible to launch contact tracing for the majority of the contacts and even offer them post-exposure prophylaxis. So in the last, I'd say 1 to 2 weeks, we have been working with the state health departments to move into the second point here, which is expanded post-exposure prophylaxis. It includes the prophylaxis for intermediate and high-risk contacts, and it also adds on a larger group of people, which are people with risk factors who are more likely to have been recently exposed to monkeypox. This is determined at a jurisdictional level. And it is often in some of the larger cities like New York City, they are gearing this towards men who have had report having sex with men, and also meet some other criteria, such as they live in a certain neighborhood or they have reported sexual activity in the previous 14 days, something like that. And then the third point, the pre-exposure prophylaxis. Currently in the United States, this is a restricted category according to our national recommendations. And these recommendations existed prior to this response. And it's targeted for occupational groups at high risk, notably laboratorians who may work with this virus in the lab. We have two medications that may be considered for treatment of severe disease or those at risk of severe disease. The first is TPOXX, which is an antiviral, and the second is an immunoglobulin. This is just the indications for use of these treatments. So again, individuals with severe disease, individuals that may be at high risk of severe disease, which include this list here, and empiric treatment may be appropriate in some other cases on a case-by-case basis. Benefit is likely greatest when the treatment is started early in illness. So to date, this is sort of some of the data from the US that we've distributed 60,000 doses of Jynneos to the jurisdictions for use, and 150 courses of ACAM 2000 have been distributed. In terms of treatment, 107 patients have received oral tecovirimat, which is TPOXX. So my last slide, what really, these are just some larger thoughts. What is making this so different from what we've known about monkeypox historically? First of all, we're seeing a large number of cases in multiple countries outside of Africa. In many of these cases, but certainly not all, are in individuals who are reported to be men who have sex with men. And I do want to point out that monkeypox is agnostic in terms of gender and sex. This can infect anyone, irrespective of being male, female, or any other gender orientation. And so we do want to make sure that people are aware and are looking for this on the differential beyond just the category of individuals who are men reporting having sex with men. The clinical presentation, I've told you, is slightly different. And so that's an important point for us in educating individuals. And the reasons for this slightly unusual presentation are really unknown at this time. There's a wide range of hypotheses, but I think it's going to take us some time to really get the data and to better understand the presentation. So with that, that's the end of my talk. Thank you for having me, and I'll be happy to take any questions.
Thank you, Andrea. Hello. Yes, Andrea, thank you, because you need to leave from other activities. We can make some comments for you and some questions, and it's very important. Hello.
Yes.
Yes. Two comments about your two comments that are very important, because one of the topic is related to the age involved. In your slides, you present some people who have more than 50 years, and one part we know the people have some prevention of possibility because they receive a vaccine from smallpox. Mi pregunta está relacionado que
my question is, in your table that you showed us, there is people that are older than 50 years old, and I would like to know if those people have had any in their history, they had vaccines, they have received vaccines.
Yeah, yes, thank you for your question. We do have patients who have previously been vaccinated against smallpox. We do see that is noted in some of the data from Africa as well. Historically, we know that smallpox vaccine, traditional smallpox vaccines used during the eradication period were approximately 85% protective against monkeypox infection. And even during the smallpox era, we knew that vaccines, even if they don't provide against infection, they do provide against severe disease and death.
La segunda pregunta,
the second question that we have is if you believe that we should have a differentiated diagnosis. I've seen syphilis because syphilis gives lesions on the mouth, on the soles, even though there's different, and habitually they're not the vesicular type. But in the Coxsackie virus, they also have similar lesions, and I would like to know your opinion on that. Syphilis, because in Spain and in England, many patients have co-infections with syphilis, but in other cases, they have syphilis and it's actually monkeypox.
Yeah, thank you for these questions. And I know it's a real challenge for clinicians as well to try to separate this out. I think we're still getting a handle on this data. I think there have been a few recent publications, I believe one out of the UK and another one out of Spain or Portugal, beginning to look at some of the co-infections. And so right now it looks like, and it may depend on the patient, their underlying risk factors and where they're presenting as well. So we're hearing about syphilis, herpes, gonorrhea, and chlamydia in particular. Coxsackie, I'm less familiar with, but certainly anything that produces a rash illness right now, and individuals meeting certain risk factors, it could be a concern for monkeypox. It's the reason why we encourage clinicians to do a full skin exam over the entire body, as well as an exam of the oral cavity.
Sí, la idea, nosotros en Perú
Yes,
estamos.
in Peru, we are seeing some infections like Coxsackie that have similar lesions. In some cases, in children, what we see are hands, feet, and mouth. It could be a differentiated diagnosis. I think we have to educate the medical staff. Most of them have a clear diagnosis, but in the graphics, you haven't made a differentiation between gender, because a message that should be clear that the infection for women, it's still rare, and for children is exceptional. So I think it would be good that you could comment on that.
It is rare currently in both women and children, but we do expect to hear about more infections occurring in those groups. I think in the US we have, it changes by day, but I think we have 5 women who have been confirmed cases. No children yet. I believe in Europe there have been a handful of children. We do expect, transmission can occur via non-sexual behaviors, of course, and if you have close contact with a patient, close sustained contact, there could be risk of transmission at this point, and particularly amongst household members, just due to the nature of the close contact or other environmental contamination.
Yes, because it still is not STD, it's not sexual transmitted, it's only related to close contact until now, and will be very important about this, because we need to tell to the population what is high risk. This is not homophobic statement. Some people don't like it to say, hey, this is the group of high risk. That is not true. We need to warning to the high risk group they can acquire, and it's very important, especially when you are asking to dermatologists or the general practitioner or people who are in the clinic of STDs. It's very important to remember all these options. But again, this group is very important, a high-risk group. And one of the comments still is not affect too much to women. And finally, don't see children. And finally, people who have more than 55 years probably are protected from this vaccine. I don't know if you are agreeing with me, because this item will be very important from the public health view and the training people about this statement. We don't need to be afraid to mention this, because this is not homophobic statement. We all the time, we defend the human rights from the gay population, etc. What is your comment about this?
Yeah, I think we have to be very clear about what we're seeing. I think we do need to recognize there are certain groups at risk. It's very difficult because it's sort of a very thin line. And we're working with a group of people who have lived their lives with a lot of stigma and discrimination. And even though if we as public health and as clinicians do not discriminate, we want to be sure that others do not as well. So I agree with you, Dr. Gutozzo. I think we do need to be clear, we need to be direct, and we need to make sure people have the data in front of them. And of course, work and engage with these communities. So we make sure that we are putting out messages and also making sure they are aware of the risk right now. And they, most importantly, seek care if they're sick and get the help they need.
there are some questions about what is your comment about the epidemic with HIV and some interaction with this monkeypox virus? You feel there are some view about that? In addition, recently there are one comment is somebody isolated in the semen the virus, but it still is not good information about the sexual acquired. Can you make a comment from these two questions?
Sure. With regards to HIV, it certainly is a concern. Individuals with underlying immunosuppression, we are very concerned about their ability to mount an immune response and fight off this virus. You know, but what we are seeing in this outbreak, and this may be attributable to several things, perhaps the strain, there's one predominant strain causing all of these infections. Are there genetic changes that perhaps attenuate the strain and make it less severe in individuals? So most of the patients that I'm hearing about with HIV are actually doing very well, and are not receiving treatment in the United States and are being monitored, closely followed, and do recover on their own. But we certainly want to make sure that people are they receive the clinical care they need. In terms of semen, there have been some studies to show PCR positivity in semen, which is positivity for viral DNA. I think we do not know if that means live virus. What does it mean in terms of transmission of the virus? And what is the contribution of potentially infectious semen to actual transmission? These are all questions, and I hope in the next year we can really help answer them.
Two final comments, Andrea. One statement is very important to the general population is to say, we don't expect to have mass vaccination, no? It's very important because some people feel, well, in the near future, we will have this. And my second comment is, you don't mention nothing about the mortality because still, I feel there are only 1 or 3 patients who die from these 7,000 people, and will be very important to present this comment. Can you do this comment to finish?
Thank you, Gutozzo, or Dr. Gutozzo. Very good questions. So in terms of the fatality rate, monkeypox causes between 1 and 11% for fatality in Africa. The 11% was in a strain that's in the Congo Basin, and that was in individuals without prior smallpox vaccination. The fatality rate in Nigeria, where this strain comes from, is closer to 1%. And that 1% is attributable mostly to individuals with uncontrolled HIV, very low CD4 counts, and I believe 1 infant, so another individual without a well-developed immune system. But in this outbreak, in the global outbreak, looking at just the numbers outside of Africa, there are 0 deaths to date. And I hope it stays that way, but we certainly want to, there have been some severe infections, there have been hospitalized cases. So we certainly want to be vigilant and provide, again, the sooner we can get patients care, I hope the better off they will be.
Okay, thank you, Andrea. Very kind, very nice presentation. I need to close. We know you are moving to other activity. Thank you to join to us. Ok, gracias.
Thank you. Gracias. Thank you.
Solamente para cerrar esta parte, yo solamente...
To wrap up this part, I would like to emphasize that we need to provide tranquility and clear information to the population about this disease and what are the expectations of a future pandemic, because people feel that or think that we'll have a pandemic similar to COVID, and this is a disease that is transmitted skin to skin, and it would be important to define this differential diagnosis. We have to insist in this. We need to understand this, and that the Andean labs should have the possibility of doing a good diagnosis. There are considerations that we need to take into account. And again, I insist in the need of saying that there are well-defined risk groups that we need to um, speak about. And well, I think with this, we close this first part. And now we go to a second part, second conference, which is a hepatitis diagnosis in the United States. We know this condition has called the attention since it started in England, or appeared in England, and then in several countries. So we are going to have this presentation by Jordan Cates of the CDC, the viral, this is division. Welcome.
That will be very nice to listen about this new infection, a new outbreak we have right now. Thank you for joining to us. Gracias, muchas gracias por estar con nosotros.
Gracias, buenas tardes. I will speak in English, thank you. And 1 second, I will share my screen. Okay.
I would like to let you know that we can select the language in the bottom part of the screen, please. For the English speaking, just stay here, and for the Spanish speaking, we should move to the other channel. Para los que hablan español, por favor, el canal de español. Muchísimas gracias.
Can you confirm you can hear me?
Yes, ma'am.
Gracias.
Yes, we can hear you well.
Thank
Yes,
you. Perfect. Okay, my name is Jordan Cates, and I'm going to discuss the acute hepatitis of unknown etiology in U.S. children. And how did this investigation all start? So in November of last year, of 2021, the U.S. CDC and local health department partners began an investigation into children with acute hepatitis and adenovirus viremia at a single U.S. hospital. And at this one U.S. hospital, there were 9 cases between October of last year and February of this year, 2022. And all 9 cases were infected with adenovirus. 5 of the 9 cases had adenovirus serotype 41, which is an enteric adenovirus. And among cases with acute liver failure, there was higher viral load of adenovirus. So in the US state where this US single hospital was located, there was a statewide notice issued in February of this year, but no additional cases were identified. However, as mentioned in the introduction, in the United Kingdom, they started also seeing similar cases. So the United Kingdom Security Health Agency reached out to the US CDC in mid-April of this year after they noted an increase in cases of acute pediatric hepatitis of unknown etiology. And so the US CDC shared this information on our single US hospital investigation and the possible association with adenovirus. And then on April 21st, 2022, the CDC issued a health advisory through our Health Alert Network, abbreviated as HAN. And in this advisory, the CDC provided recommendations for adenovirus testing and for reporting of children with acute hepatitis of unknown etiology. And these children were to be reported to local health departments and also reported to the CDC for national tracking. But a little background about hepatitis in children. So hepatitis, the word itself is just referring to inflammation of the liver, and it's a general term, and the word itself does not specify the cause of liver inflammation. There's many possible etiologies, including infections. Primarily, you think of hepatitis virus infections. In the United States, the most common hepatitis viruses are A, B, and C, but there's also hepatitis viruses D and E. Medication toxicity could also be one possible cause for hepatitis, as well as immune dysregulation and metabolic disease. And at baseline, in general, there is estimated to be approximately 30% of pediatric acute liver failure that is of unknown etiology. And for adenovirus type 41 is an enteric adenovirus that generally causes mild gastrointestinal illness. And adenovirus type 41 is recognized as a cause of hepatitis in immunocompromised children, but is not considered a cause of hepatitis in healthy immunocompetent children, which is why these initial case findings were unique. So the United Kingdom Health Security Agency has issued several briefings on their investigation, and as of May 19th, had reported 197 cases of non-A through E hepatitis identified in children under 16 years of age. Most cases were under 5 years of age, and they noticed that there tended to be gastroenteritis type prodrome that was followed by the onset of jaundice. And adenovirus was detected in approximately 70 or 68% of cases that were tested. And of 27 cases that were subtyped in the United Kingdom, all were serotype 41. The United Kingdom was also noticing that community transmission rates of adenovirus were increasing in the UK since the end of 2021. They also noted that the most common additional pathogen detected was SARS-CoV-2 in approximately 15% of their cases. So all of this led to a leading hypothesis that a cofactor affecting young children is potentially rendering normal adenovirus infections to be more severe or causing them to trigger immunopathology of some type. However, we do continue to explore and investigate the role of SARS-CoV-2, as well as the UK is exploring this, and are also working to rule out any toxicology component. The World Health Organization is also tracking global reporting of severe hepatitis of unknown origin in children. And as of June 22nd, the WHO had received 920 probable case reports from 33 countries, although a majority of cases have been reported from the United States and the United Kingdom. 78% are among children under 6 years of age. 45 or 5% have required liver transplantation, and 18 deaths have been reported to date. Among cases that have been tested for adenovirus, approximately 50% have had adenovirus detected. And for SARS-CoV-2 detection, 14% of cases have tested positive for SARS-CoV-2. For the US investigation, we are tracking patients under investigation. We use this terminology because we're still learning a lot in this investigation, and we hope to further clarify a concrete case definition as we learn more. So for now, we use this terminology, patients under investigation, abbreviated as PUI. And this is defined as children under 10 years of age with elevated aspartate aminotransferase or alanine aminotransferase who have an unknown etiology for their hepatitis, independent of adenovirus test results. And we retrospectively requested case reports on patients under investigation since last October. We've been collecting data using 2 data collection forms, the first of which is a medical chart abstraction form. And the second form is a case report form assessing exposures that is done by a parental interview. So we've learned a lot so far. We've received preliminary reports of 332 patients under investigation. And this is reports nationwide in the United States. They're geographically distributed and are not clustered in certain latitudes. These cases are also not concentrated in time and have been reported over the entire study period from October through June. Most cases, so about 90%, were hospitalized. There have been 20 patients, about 6%, that required liver transplant, and 11 deaths are under investigation. 45% of PUIs with testing for adenovirus had detection of adenovirus, and 13 of 20 that were type 41. So the majority were adenovirus type 41. For SARS-CoV-2 detection, there was current infection in approximately 10% of patients and reports of prior infection in approximately a quarter of patients. The chart abstractions in the parental interviews have found no strong signal for other risk factors, including toxins, drugs, or other exposures. This figure here shows our epi curve looking at the number of patients under investigation over time by the date of hepatitis onset. And you can see while the reports of patients are spread over time, there is a peak at the end of April that coincides with when the CDC issued their health advisory. This figure shows that multiple pathogens were tested for among these patients, although testing did vary by treating clinicians. And the most commonly detected pathogen, as already mentioned, was adenovirus. So all of this indicates that adenovirus may be the cause for these reported cases, but we're also exploring other potential exposures, such as medications, other infections, toxins, food, water. We're keeping an open mind as we're learning a lot about these patients and casting a broad net. And we aim to focus the investigation more over time as we learn more. We have several specific questions that we're aiming to address. The first is to understand to what extent we are seeing an increase in pediatric hepatitis of unknown etiology. Is this focal or is it nationwide? Is this really an outbreak? So to address this question, we looked at syndromic surveillance nationwide. And here, these two figures show that there is no increase in hepatitis-associated emergency department visits in the United States from 2018 to 2022. The figure on the left shows emergency department visits with hepatitis-associated ICD-10 codes among 0 to 4-year-olds, and the right figure is among 5 to 11-year-olds. And you can visually see there is no deviation from pre-pandemic trends. Similarly, when looking at hospitalizations, data show no increase in hepatitis hospitalizations in the United States from 2019 to 2022. This figure is looking at hospital admissions stratified by age group again, with the darker line, children age 0 to 4, and the light blue line, children age 5 to 11, with minor changes over time, but no increase over time. We also looked at actual pediatric liver transplants that occurred in the US from 2017 to 2022. And even though numbers are quite small for this, we see no increase in liver transplants among children over this time period. Secondly, we want to know if this is primarily due to adenovirus. Why is it happening now? Are we having a large adenovirus type 41 season? Is there something unusual or unique about this strain? So we also looked further at our data on adenovirus. And this slide shows two figures looking at trends of enteric adenovirus. So that's adenovirus types 40 and 41 in the United States from 2017 to 2022. Also stratified by age on the left, 0 to 4 years, and the right, 5 to 9 years. And again, indicating no increase in adenovirus percent positivity over this time period. Although you can see this big drop in percent positivity during the early pandemic eras, but no dramatic increase in percent positivity in the recent year compared to pre-pandemic baseline. Our third question to address was, what is the etiologic role of adenovirus, and specifically adenovirus type 41? One way we looked at this question is starting to sequence. There is preliminary sequence data. This is still ongoing, but preliminary sequencing data suggests that there are multiple different strains of adenovirus type 41 that are circulating, and that these detected strains are similar to known adenovirus type 41 strains. So this is not suggestive of there being a new variant. We have several lines of evidence that support the role of adenovirus. So the first of which is that infection, particularly infection in the blood, so adenovirus viremia, has been seen in more than 2/3 of patients. And this is consistently seen across many countries. We're finding it in the United States, finding it in the UK. And there is some data showing that children that had greater viral load were required transplant. Third, this age group of young children is a typical age group at which children get adenovirus infection. Also, this age group may have increased susceptibility from lack of exposure during the early parts of the pandemic. Additionally, some patients have preceding gastrointestinal illness reported, and we know that adenovirus type 41 is typically a cause of gastrointestinal illness. And lastly, to date, there's no clear alternate hypothesis so far. However, there are a number of lines of evidence that question the role of adenovirus, so it is not a clear-cut answer. Adenovirus historically is not a well-recognized cause of hepatitis in healthy children. And of the pathology that's been done during the current investigation, pathology results have not been consistent with typical adenovirus hepatitis that's seen in immunocompromised children. Importantly, to date, there has not been evidence of viral infection detected in the liver itself. Metagenomic studies that have been conducted so far in the UK have not found high levels of adenovirus infection in the blood, although they have found high levels of a virus called adenovirus-associated virus 2, abbreviated as AAV2, which is not known to be a pathogenic virus and is thought of as a non-pathogenic parvovirus. So there's more to investigate with AAV2, and studies are ongoing for that. And finally, as mentioned, there's limited sequencing data that indicate there are multiple strains. So there's not a clear single strain of adenovirus type 41 that is circulating among these patients. Another question is, are there other pathogens or cofactors, for example, SARS-CoV-2, that could be playing a role? And this begs the question of how might SARS-CoV-2 be related? Could it be acute SARS-CoV-2 infection that's leading to hepatitis? We think this is less likely, considering that less than 10% of patients under investigation in the United States had current SARS-CoV-2 detection. However, could it be that there is recent or history of SARS-CoV-2 infection that's triggering an immune dysregulation of some kind? So is there overlap of this hepatitis presentation with multi-system inflammatory syndrome in children? Or there's also a theory called the superantigen theory that questions whether persistence of SARS-CoV-2 infection in the gut could be a cofactor. And lastly, could it be that pandemic mitigation measures have created immunologic changes in a large cohort of children due to a lack of exposure to many common childhood viral illnesses? And as a result of these mitigation measures and lack of exposure, might some children exhibit a dysregulated response to their first adenovirus infection? And if this last part's the case, it's possible that perhaps this association with adenovirus and hepatitis has been occurring for a long time, but always at a low level, below a threshold of detection at a level of public health. Regarding the question about overlap with MIS-C, MIS-C associated with COVID-19 most often presents with cardiac or renal organ involvement, but occasionally signs of hepatitis. Among over 8,000 US patients with MIS-C, less than 1% developed liver failure, and nearly all of that were secondary to shock. So it does appear to be distinct from MIS-C, although we continue to explore this. The final question really is, what can be done for prevention and control? And that question, unfortunately, is really hard to answer because it requires us to identify the causative agent to be able to provide prevention and control measures. So in summary, national US data do not indicate an increase in pediatric hepatitis emergency department visits or hospital admissions, liver transplants, or adenovirus above pre-pandemic baseline levels. And in the United States, counts of patients under investigation have been declining since the health advisory was released in late April. Adenovirus is the most detected pathogen in about 45% of US patients under investigation, although early sequence data does not support a new adenovirus variant with increased virulence. Few cases are co-infected with SARS-CoV-2 at presentation, but we are investigating the role of prior infection or persistent viral shedding in the gut. So we've learned a lot, and a lot has been learned on the global scale as well. But we have several next steps. We continue to collect data and describe and analyze data from these patients that are under investigation in the United States. We're working to establish a prospective hospital-based case control study to really further answer this question about the association between adenovirus and pediatric hepatitis. We plan to test stool for SARS-CoV-2 and do antibody testing on acute cases to further explore this possible etiology as well. And there are multiple additional pathophysiology investigations that are being conducted by CDC in partnership with many other federal and academic institutes in the United States. These include additional tissue pathology evaluations, metagenomic evaluations, attempts to grow adenovirus in liver cell culture, and immune dysregulation studies. So this is my last slide, and it's a screenshot of our website just to show where we provide the most up-to-date information. It has a general overview of the investigation in the United States. It provides clinical guidance as well as information for adenovirus testing and information about submitting specimens to the CDC. So I will stop there and thank you so much for your time.
Okay, thank you, Jordan, for the very nice review about this new condition in infectious diseases. Tenemos algunas preguntas que es importante.
We have some questions that we'd like to respond, because this is analysis from the cases of the US, but in the global arena, we know that close to 80%, we're talking about children under 6 years of age, and it's the same distribution between men and women. So something important to highlight, in my opinion, is that the initial criteria is to discard the common hepatitis that we have in Latin America, A, B, C, and D. And it's important to take consideration to have also discard the E hepatitis, both for the oral and systemic infections. And this is important because the viral hepatitis, it's always associated to yellow fever or delta hepatitis. So it's quite important to raise awareness about this condition. Something that's true, it's that the disease is quite severe because you don't make a transplantation for children, because we have a mortality rate from 2 or 40% that is quite high to find this finding, or to report this finding. So my first question is related to the fact that many times when people feel nausea, vomits, or fever, you receive some medication, and will be nice to recognize what are the medications that receive children when they have fever or vomits. An important memory is that when we provide treatment for smallpox due to ibuprofen, we increase the rate of septicemia due to Strep aureus. So maybe the use of some medications might promote the clinical course into a more severe form. Have you ever worked or analyzed the options of medications that the children receive to know if there any association between the medication that they received previously against fever, against inflammation, or to prevent vomits?
Thank you for your comments and for your question. We do gather information on medications and treatments that were received during the course of illness and in the 2 months prior to illness onset, and have not seen any patterns in medications that might be causing toxicity. We do recommend that Tylenol, I can't think of the generic name, but for pain relief or fever reduction with Tylenol. That can be associated if there's high levels of Tylenol, can cause hepatitis toxicity. But so far, there's been no indication that medications given for other aspects of treatment for these clinical symptoms, for GI symptoms or systemic symptoms, are causing the hepatitis. But we continue to investigate and are looking at medications very closely.
Paracetamol is the medication. Paracetamol, right?
Thank you. Thank you.
You're welcome. So I would like to ask if there are any socioeconomical factor that you can address in terms of the association with this hepatitis. It will be very interesting to recognize if we have, for example, higher risk into a particular socioeconomic group. We know that the main group affected by this condition is children under 6. We know that it's not associated to COVID vaccine, right? Because it's important to alert the general public that this is not a condition associated to the vaccines. These are groups of children that are not vaccinated to COVID, but we see that they present also COVID together with this new condition, but it's not reported this cause-effect relationship with the vaccine previously applied, right? Any comment on that?
Thank you for bringing that up. That's absolutely correct. There is no connection with the COVID-19 vaccine. These children are too young or were too young at the time of the investigation to receive COVID-19 vaccination based on their age. And I think there were only 3 children out of all approximately 300 patients that had received any dose of COVID-19 vaccine. So not important to communicate that this is not related to vaccination, but we're continuing to explore whether infection with COVID-19 or prior infection with SARS-CoV-2 COVID-19 is a factor. As to your question about socioeconomic status, we're continuing to look into this. We have questions that we added to our chart abstraction and to our parent interview, trying to better capture and understand the socioeconomic status of these patients to see if there are any links. We are still getting that data coming in, so don't have information on it right now. We are seeing very broad geographic distribution, so that has not been a link, but we're continuing to look at socioeconomic factors as well.
Sí, muchas gracias, porque claro, es una...
Thank you so much, Jordan. We know that this is a disease that from April 5th, in 10 weeks, we have been reaching 920 patients that are the known reported patients. It is very likely that we have other patients that are not reported, but it is quite surprising how rapid these reports are evolving. So there's a need, I'm sure that there's a need to work together with regional cooperation, and I'm sure that the Andean Health Organization will support this initiative. I think that will be important to strengthen the agreements to monitor this new infectious disease that is generating a more severe clinical course of the disease, many times or sometimes needing transplantation or specialized care, and a mortality rate that is quite shocking because this is not a traditional reported mortality rate connected to previously reported hepatitis. So this is an important occasion to report these 920 cases. I'm sure that in Mexico, we also have some reports. In Argentina, Brazil, and Panama, we have from 1 to 3 cases. Peru, Bolivia, North Chile have reported any cases that are related to this condition, but I'm sure that it will be important to review the guidelines and to start testing in order to strengthen the capacity building and the surveillance of this acute hepatitis in children. Will be extremely, extremely important to prioritize our region, our surveillance strategies in our region. Thank you so much, Jordan. And we will move now to the next lecture. Thank you so much for your time.
Gracias a todos.
Okay. Muy bien. Vamos ahora a una siguiente charla, que es la última charla.
Now we will move to the next session.
Que va a estar relacionada precisamente a lo que quisiéramos fortalecer, que es colaboración entre el CDC y...
And we will talk about collaboration and CDC and South America to improve the systems of surveillance that were discussed. And we need to strengthen the surveillance, diagnosis, and prevention.
And along those lines with us, we have Dr. Juliet Morgan. Juliet Morgan, she graduated in the University Buenos Aires in the UA, but she trained in the United States and she finished in Emory, and then from there she has had a um, long research career. She has worked in Chagas, malaria, and then she has worked in leptospirosis, among other things. She has worked in areas as Mozambique, in Africa, but she has been also in Jakarta, and she is now in Brazil, and she is responsible for the CDC for level for South America. So without no further ado, I would like to introduce Juliet. It's always a pleasure to listen to you and to know your objectives as responsible person for this office. And we will always be interested in strengthening our connection with organizations as a CDC. So welcome, Juliet. Well, thank you very much for the invitation, and also thank you very much, Dr. Gotuso, for the introduction. It's a pleasure. It's always great to see colleagues that we are trying to deepen into collaboration. Well, I have some slides, and I hope we can share them. Yes, you can.
Todavía no. Ahora sí.
Now we can see it. Well, as you can see, the title was collaboration between CDC and South America in terms of the strengthening of detection and response systems. And I am going to give an example of one of the activities that we are developing, but more than anything, I wanted to use this opportunity to describe our presence in the region, since it's different than what we had before. And so the participants can understand our mission and how we want to deepen into our collaboration, especially with existing networks like Horizontal and other academics and entities, and of course, with always with the ministries and public institutions. So I am going to take this opportunity to speak about the regional office and some of the efforts that we are doing. First of all, see, Well, this is not as relevant, but it's to take into account our strategy, our global strategy. CDC is changing its approach in terms of its international presence and regarding the support for the countries. It's a change, and we are in that process. We're developing the strategy for global health. We want to keep our focus in promoting health globally and maintaining our presence in a sustainable manner. In that sense, this represents a shifting point for the work that CDC did at the international level. Now, you might not be as familiar with our offices in other parts of the world, but in South America, we have not had a much physical presence. Even though we have several projects with the different countries, we have not had an office as we have in Africa or Asia. Historically, in most of the countries, we have established offices that work in a bilateral manner, that is directly and only with the country where the office is located. And that is the example, very common. Many offices there, but most of them are dedicating to PEPFAR and for HIV. In 2014, when we saw Ebola outbreak, which caused a health emergency, the CDC spinned little and switched its focus to provide training for the countries and to be able to so they could comply, or there was more adherence to sanitary regulations. And in that sense, more offices were established, focus on training to comply with international regulations. Obviously, after Ebola, it was proven that at the global level there was a necessity to increase their capacity to prepare for the next threat. This graphic represents the regional level and how we see the support and the functions of public health that are basic. And we would like to align each activity, or we support each technical assistance. We want it to be in line with the blue part, uh, where we are talking about training, surveillance for health, obviously, and labs, and of course, in in the workforce area for public health, where historically we had many activities in the FETP program, and as always, the research. So all the activities where, or specific activities where we bring technical assistance from our specialists in Atlanta, the idea is that each activity has or is able to fulfill that objective of creating training in these areas specifically. There are obviously priorities at the global level, and these areas are a priority for us, especially uh, antimicrobial resistance, border health. If we have learned something, border health is very important to keep our economies and our societies. There it says honor salud, but it means honor salud, the interaction between human and animal environmental health, and of course, the threats that come from virus and other pathogens. Of course, these areas are have this components training, formation, in epidemiology and surveillance and research. If with the intention of keeping that presence at the global level that is sustainable, it was evident to us that keeping offices, bilateral offices, that were only working with a single country wasn't a sustainable vision. And most offices are financed by a single health program, in this case, PEPFAR, or another or a specific program. Now, the regional office is well, depends on financing that is not necessarily directed by a program, but the financing in CDC in general. So we have a long-term presence here, and that is why it's so important to develop our collaboration and our relations with the entities that already exist in South America and the networks that work well and that we want to um, uh, collaborate with. The regional office is in the middle of all this, and as you know, we cover 13 countries of the region. Obviously, and speaking about specific um, surveillance, you know, as well as I, that what we need are systems, necessary systems uh, for health, and those systems include surveillance, lab, and those systems depend on information systems for health that are used to achieve the objective we are all searching for and that we have learned the pandemic, which is these systems need to be functional. They need to comply with the objective of informing authorities in real time about the situation that is the situation of each region globally. Without information, we can direct and generate the different changes in the response to ensure that the response is efficient and capable of containing any threat. Obviously, these health systems, uh, environmental systems, lab systems do not work without having a workforce. but also not only to put data together, but to interpret data and to be able to communicate data for the authorities needed for decision making, but also for the audience that does not understand, that does not speak the same um, language than us. And without having that communication, that clear communication with the audience, with the general public, the behaviors or the interventions to contain a threat without having that communication will not be useful. In this sense, I would like to give an example, um, because what I want is to offer our participation in these networks and offer our interest through the regional office and facilitating all the assistance and all the collaboration. We are in the region, we are working with you, we are learning from you, we are understanding what are the needs, the challenges, and we can communicate that to Atlanta and to bring that collaboration with the specific areas in Atlanta and to bring that so we can work it together. An example that I wanted to highlight is the workshop that we are organizing and that I think is the first step in trying to provide that support, identifying our role, and next to the colleagues of OPS to identify which are the areas in which we can provide support. And I think that this workshop, we are working with 7 countries. It includes Ecuador, Peru, Colombia. It includes Brazil, Argentina, and Chile. I think Uruguay as well. It's a workshop where we see this as a first step to have an opportunity like this to bring the different countries and to share lessons learned and to start to focus on surveillance and specifically in information, health information, to be able to identify how is it we can work together to improve in these areas. Now, this is a workshop, as you might know, that we have tried. We're working with a consultant and we're trying to connect with the different colleagues in each country. And we are going to organize the workshop in October to be able to share some of the experiences that we have had with the expectation of a next workshop where the scope will be the modernization of health systems and the integration of health systems. Now, for this workshop, we use this graphic that comes from the OMS and the OPS and the CDC. We are in line with this and excuse me, it's in English, but as you know, this is an area for surveillance and information for health is very important for South America and the world. It's important to modernize the system and to make the most out of technologies that are available. As my um, daughters like to remind me, we are living in the information, time of information, and we need to use um, those technologies. Now, an emphasis in leadership and the decisions based on evidence. That evidence is necessary to have them, to have information based on evidence, emphasis on the formation. It's not only the workforce, uh, but also uh, workforce that knows how to interpret data and communicate data, and also an emphasis on innovation. So the workshop is focused on that since these are some of the examples, excuse me, because it is in English, but these are the challenges for um, surveillance and to characterize the epidemiological situation in the country and knowing the differences, understanding the differences in the different indicators for each country, and of course to have a presentation on the analysis of the situation and the systems, information systems, and which are the challenges, common challenges. The primary sources of information, the best practices across the region, what are the common approaches, and which are the challenges. And each country will give a presentation on its components. And as I said before, this workshop is trying um, to do this at the regional level to be able to share our challenges, our common challenges, and to try to have that vision. What's happening in Peru, what happening in Ecuador is important to work for people in the United States or in Uruguay and in other countries. And if we develop that uh, regional culture and global culture, this will benefit all of us. As I said before, this workshop is the first step for future workshops that will have a specific scope on modernization of the information systems for health. And this workshop that we are trying to implement and have it in March 2023. And we would like to take all the efforts of modernization of the health systems because we see that the obstacles, one of the great challenges that suffered the United States and that CDC was really in front of it was the lack of systems that speak uh, that between states and to a central system. Those systems do not quite exist, and there is an effort for modernization of this. systems in the United States, and we want in the regional office to take those lessons learned together with the strategies that are being developed with the OPS, OMS, and to put our efforts in line, see where are the opportunities to modernize the systems. And also, and not only modernizing the system, but starting that integration that is lacking between the systems, lab, not only the labs that in the sector, the public sector, but also the private labs, clinics, and academia, and how we develop a system where there is interoperability and capacity to communicate and also with environment and agriculture. Well, this is what I wanted to, the examples I wanted to give and our future ideas on two aspects that we believe are very relevant for, well, to continue on this common objectives of improving our surveillance. And with that, I'm over. It's been a long day, so I wanted to keep it short and focus on the activities. Well, thank you very much.
Juliet, muchas gracias.
Thank you very much, Juliet.
Creo que muchos de los que
I
estamos en
believe
esta
that
área
many of us in the audience
contentos de
are very
conocer
happy
tu mirada,
to know about
grandes
your
barreras que
vision.
sí han
One of
producido que
my
se aprende cómo Europa, que tiene
one of the things I've always thought is
40
how
países, puede
Europe
hablar como 30
has
lenguas y que tienen 15
40 countries with 30
religiones y
languages
han
and
tenido
15
muchas
religions
guerras entre
and
ellos
have many wars
coloniales
among
para
them, and now they
enfrentar los
have
pueblos
a
europeos.
dialogue
Entonces, en
to
América Latina
confront
hablamos el
uh,
mismo lenguaje,
Europe. In Latin America, we speak the same language, we have the
y
same
por desgracia
history,
no podemos
and we cannot
todavía juntarnos porque, digamos, los microbios
we
tienen frontera con todo lo
cannot
que pasa a tu lado.
uh,
Y en
fix
segundo
these
lugar,
problems again.
la pandemia
Microbes don't have
claramente ha
borders,
indicado que
and
tenemos que trabajar
the
en
pandemic
conjunto,
has
tenemos
shown
que
us that we
unirnos.
have to work
Y
together.
no,
There
si
is
no
no
tenemos una
option
buena
but
vigilancia,
to
porque lo
have
que puede
good
aparecer hoy día en México
surveillance,
o en
because
el
what
Amazonas,
can
como mañana puede
appear
terminar
in the
en
an
Cuba, que
Amazon
terminar en París, es decir,
town, it can
muchas
end up
cosas
in
distintas.
Paris
Y
the
yo
next
creo
day.
que es
So
muy
I think it
importante
has been very important,
esta presentación tuya y este
this
esfuerzo de la
presentation
Oficina Regional del CDC,
of the regional office of
que
the
sabemos que
CDC,
muchas personas
and
vamos a
we hope
estar
that
muy
many people would
contentos
be
de
very
tu
happy
condición.
to know
Felizmente
about
el Perú está el
this.
país
As
que más
in
logros ha
Peru, there
logrado,
are
dificultades, como tú lo has
many
mencionado,
difficulties, as the
que
ones
no hay
you have
interacción
mentioned. There
entre
is
lo
no
público y lo
interaction between
privado,
the
la
public,
academia,
private,
casi en
academia,
todos los países
and
de
we have
América
seen that
Latina.
in all
Entonces
countries
la
of Latin
pandemia
America.
hizo muy
There has we
juntarnos
hasn't
aquí y
been
juntar los países y
a
enfrentar eso.
joining
Por eso
effort,
fue lo
a
que
joint
me ha
effort.
apasionado mucho
So I
hablarte.
think what you have mentioned is very important.
Ahora hay un comentario, por ejemplo, la doctora Rocío
For example,
dice que
Dr.
se debería
Rocio
reglamentar
says
que,
that
digamos, todos los sitios
all
contaminados
the
y eso.
contaminated sites,
Nuevos enfoques de epidemiología son
the new
importantes
scopes are
y
important.
todos conocemos
And
cómo
we all
en
know
nuestra
how
región
in
tenemos
our
sitios
region we
desérticos como
have
la costa del
the certic
Pacífico,
sites,
tenemos sitios
but
de valles
we also
intermares,
have
valles
inter-Andean
salines,
valleys.
tenemos áreas de
We
zonas de
have
selva
uh,
y tenemos finalmente la selva con más de 80
rainforest with more than
ambientes
80
ecológicos diferentes que
different
son afectados,
but
que por mucho son
ecological
casi
areas.
toda el
And
área amazónica. Así que lo que tú
so
estás
what
comentando
you
de ponerse a
comment
hacer una
the effort
vigilancia
of doing
institucional
institutional
institucional,
surveillance
etcétera, significa que tenemos que tener una actitud de
means that we
cooperar, de
need to
trabajar
have
juntos.
this
Así que
cooperation attitude.
yo quisiera
So I
agradecerte,
would like to thank you. I
especialmente
don't
por el
know if
comentario de Rocío,
there have been more
de
comments.
Espinosa y de Digesa, y
maybe open for a last round, but I agree that it's been long, very good, fruitful day. I don't see any other questions. I don't know if you want to close your presentation. Well, first of all, yes, I don't know how to close. I we can see you. Okay, I don't know how to close this.
Ya no vemos su presentación, doctora.
¿No
No
ven?
estamos viendo. No, ya no.
Cerramos tu
Ah, ok, muy
presentación
bien.
y quedas tú.
Ok, muy bien. No, en cuanto a la
Yes,
pregunta,
regarding the question, a lot of experience in communicating risks in this new epidemiology section. I think communicating risk cannot be underestimated. That is super important, and we are open to collaborate in this sense. I agree with Rocio. This is an area highly important because risk communication in a place does not necessarily mean the same in other regions. So I agree with that. We are open for collaboration. And to comment on what you said, Dr. Bertuso, the pandemic taught us that we need collaboration. No one knows everything. We need openness, and I think that the office opened, we had it planned, and we have the pandemic, but I think it was a very good opportunity for us to be able to speak, communicate, and to establish relations with the different um, collaborators because we all understand and speak the language of public health. So we agree on that. We need much more collaboration, and this is why we are here. Thank you very much to you. There is a comment. Patty Garcia says, fantastic that the CDC now migrates to South America. I think um, it will be a very good interaction. Again, this vision that is not only the public sector, but all sectors has been a difficulty during the pandemic. There has been a lack of interaction, professional schools. So, and respecting interaction. We all want to educate and to have early diagnosis and to do surveillance, immediate surveillance, because they tell you, well, 4 months ago this happened, but yes, 4 months ago, but now what happened? So what we need here is to have information on what happened today, and for that we need to join efforts. And I think that this message has been very, very important for all of us. Many times there are a group of people that think that the government is the only one that has the capacity of doing things, and that does not give any results. That is the way of um, solving initiatives in the United States. For example, uh, one of the things that the CDC does is it works with universities and the civil society. So I think it is a refreshing view or refreshing vision for people like us. I've been 50 years working in a public hospital and I'm in the academic life, and we need that scope. Well, with that, we would like to thank you and to thank uh, your presence we will continue insisting that one of the main important parts that one of one of the things important in our region is to get more than 90% vaccination rates. We're not saying only older people. I think these discussions are very useful, but let's not change the spot, the priorities. We need to continue doing things, and I think that for the audience should be clear that still in our region, the pandemic is active, and we need to strengthen the concept that from all ages we should have get our vaccines because of the proven benefits of it. So it has been a very fruitful day. I thank you for your presence, your collaboration, and personally, I am very happy that we can be together in this meeting. And I wrap up with this, and I'll pass to Dr. Bengolea for the final remarks. Thanking you again for this honor of moderating this session.
Thank you so much, Dr. Gotuso. It was an excellent afternoon where we share knowledge in some processes that will be an important strategy for public health surveillance. We are in agreement with all the cooperation that went from Juliet Morgan presentation, where we are extremely thankful for the lecture and presented the how we are going to work in the future years for CDC in the Latin American countries. Together with Dr. Andrea McCallum and Dr. Jordan Case that share with us brilliant presentations about this topic and especially the unknown hepatitis. We agreed of articulating the efforts not only together with the ministries of health, but also all the instances to respond to this pandemic that made evident some aspects. This pandemic changed the way we live, and it is still leaving us completely vulnerable in some areas, and we need to articulate every single one of the capacities we have in order to shape a team of stakeholders that imply the need of having information but administered correctly and have the answers with every single stakeholders and the problems that we have to deal with. And I would like to wait for to appreciate Dr. Gotuso and bring and Dr. Garcia as well that allowed to have key information that will be useful to be a baseline to establish a series of activities and actions related to responses. The response of the Ministry of Health, the capacity that were developed, the difficulties, and the need of retake the Andean network of epidemiological surveillance that will be extended to the network, and we tested and give us good results. I would like to share with you some the support of academia with the control epidemiological. In other instances that generate capacities to the formation to support the health staff that will help us to co-participate in the experiences we had. And next, we will have an intervention related to the topic of surveillance. And I will let you know that the experience of the system, of the health systems,
Esto nos va a servir también como una instancia académica, desarrolla capacidades e instrumentos tal como lo hizo la Universidad de Johns Hopkins.
This is something that will help us to have Johns Hopkins University that has a series of parameters and guidelines to have new knowledge in terms of the online information that will be useful to obtain an harmonized response. And the most important thing about all the sessions will be how the ministries of health give response to the pandemic, how the difficulties and support, and also what are the proposals that we will need to work in the future. And I will require the assistance of every single individual of the network. And this is not going to finish. This is not going to be the end of it. We will retake the Andean Forum of Surveillance and Public Health as an instance of technical competencies, scientific approaches, and also to organize the decision-making process. I will leave the microphone to Dr. Marisela Malki, our Secretary of Joint Efforts, to close this event.
Gracias, Luis. Muchas gracias.
So I would like to thank every single participant that we have along the day in this presentation. Basically, the ones that were working with us during this afternoon, Dr. Andrea McCollin, Dr. Jordan Cates, Dr. Juliet Morgan, that we have the pleasure of meeting personally after her visit in Lima, and for which we are interacting to create some important alliances in this field of public health. Without any doubt, it was a very rewarding day in terms of information and access to information that will allow us to strengthen our strategies in public health. So I think that the best decision was to revive this forum that was illuminated by the presence of many speakers and our deepest appreciation for every single participant of the Orascons region from Chile, Colombia, Ecuador, Peru, and Venezuela. I would like to invite you to keep with us in the second session of the forum tomorrow morning to keep connecting within this important event for the public health of our dear region. Thank you so much and have a wonderful afternoon. I'm sure that we are convinced now that putting together alliances and efforts, our efforts will respond better because we're convinced that together are stronger. And that's how we will optimize our resources. So scared after the pandemic, we need to take advantage of them. Thank you so much and see you tomorrow. We would like to invite you to turn on your cameras so we can take a final picture to say goodbye. Please let us know if you can do it and turn on your camera. Thank you so much.
Una omisión muy fatal, agradecer de manera muy especial a nuestro querido doctor Eduardo Gotuso, que siempre nos acompaña en diversas actividades de Orascon. Ya lo consideramos parte de nuestro quehacer. Muchas gracias por la excelente moderación, doctor Eduardo Gotuso. Gracias.
Gracias. Janet, la foto, por favor. Muchas gracias. Hasta pronto.